For your kind words, Mr. Chairman, sir. At the outset, many thanks to Dr. Jasuja and Dr. Sagar for giving me the pleasure and honor of speaking today. Hypertension is a common topic between cardiologists and nephrologists, and I think between us we can talk for a long time. I, however, will try and not keep you too long from lunch. I have no disclosures related to this presentation. So the elephant in the room is Symplicity 3. This is the trial published in the NEJM April 14th, where it was shown that there does not seem to be much difference between people who were offered renal denervation versus people who underwent a sham procedure. And it's given us an opportunity to rethink which patients should be sent for this procedure. So the initial publication came out in 2009 when a patient who had been on 7 antihypertensive agents and was not well controlled was given this procedure and seemed to improve a lot. It is thought that the sympathetic system is the main modality which, when diseased, leads on to essential hypertension. And in 2009, Henry Kroom and his colleagues from Monash, Melbourne, published Symplicity 1. So 45 patients were taken up for this trial, and they studied people who went for the procedure vis-a-vis people who were on control and did not get the procedure. And this trial went on for 3 years, and what you have is, after 3 years, there is a considerable benefit which starts off very early, within a month, and extends all the way out. And after 3 years, we find that the systolic blood pressure is improved by around 33 and the diastolic by around 19, sorry. The catheter itself is very simple. So the procedure involves the RDN Medtronic catheter here. It's a radiofrequency electrode tipped catheter. What you have is a generator which again does not allow more than a certain safe amount of energy to be delivered. The catheter is introduced through the femoral artery. A sheath is passed over a wire, and then the catheter engages the femoral artery. And then we move the RFA catheter within the sheath and out distally into the renal artery. Multiple burns are given. These are treated from distally to proximally, 4 to 6 focal treatments given, and the mean procedure time for the initial catheters was around 40 minutes. Now it's down to around 24 minutes for the same catheter. And why is this effective? Well, it's thought that around the renal arteries, both the sympathetic and parasympathetic system run in a circumferential fashion, and they are very close to the surface. So even a small amount of burn given here is enough to cause denervation without really causing too much damage to the vessel itself. So why is this thought it may work? Like I mentioned, essential hypertension often related to disease of the ANS. Through the renal sympathetic efferents, there is increased nerve activity which flows to the brain and the vagal nucleus, and again on the way back there is increased flow which is mediated by the renal efferent nerves, which causes increased sodium retention and decreased renal blood flow. So it's thought that by modulating this, we will get the benefit of denervation. Like the chairman mentioned, in the past, surgical sympathectomy was carried out, but most of these people, although their blood pressure would come down, they would fall over from postural hypertension or be impotent. Leading on from this, Symplicity 2 was published. This is from 2010, and the 6-month study again shows a systolic blood pressure improvement of 32 and a diastolic of 12. So at this stage, this came into its own, and before you knew it, there was a stampede for people trying to get into the program. And at one stage, there were around 80 catheters which had been approved for the procedure. These are the most famous ones. We have experience with the Boston Scientific Wessex catheter and the St. Jude's catheter in our own lab. So in the Prince Charles, we over a period of 3 years, we enrolled 37 patients. In the Wessex catheter, we had with the Wessex catheter we had 11 patients, and with the St. Jude's catheter we had 26 patients. These people, when they were drawn out to 6 and 12 months, we found that there was a mean office reduction in blood pressure by 19/10, and the mean ambulatory reduction, that's a 24-hour blood pressure monitor, of 9/6. We did have our own share of complications. There was one renal artery dissection which was stented and the patient remained fine. There was one renal artery stenosis which was again studied in 6 months with a repeat angiogram, and that remained fine with no hemodynamic compromise. So as far as the Wessex goes, out of 11 patients, we see that we got a nice response in 8 of them, a total mean reduction of 22 millimeters, systolic and diastolic 16. But 3 out of 11 were non-responders. So I think it's important to realize that this procedure is not for everyone. And as was found out in Symplicity 3, which was a blinded sham controlled study, and that has changed everything. Now this procedure is in stormy waters, and some people may think that it has actually crash landed. So a quick overview about Symplicity Hypertension 3. This was from 88 centers in the United States. 1,300 patients were studied and 544 got into the trial. They ranged from 18 to 80 years old, and they were randomized in a 2:1 fashion to either the denervation or just a sham procedure. In the sham procedure, all these people, they got anesthesia, they got a femoral puncture, and they got a renal angiogram, and they did not know whether they qualified for the denervation. Now these people were enrolled between 2011 and 2013. The 6-month follow-up was done, and in January this became public, and at that time suddenly we realized that there was not going to be much difference between the two groups. So this was the design. All these people have been screened with the initial screening. They have been assessed at home, in the office. There was a confirmatory screening. Then they had the 24-hour blood pressure monitor and went on for randomization. And there they received the renal angiogram, and some of them got into the study group and some of them got into the sham group. So the efficacy endpoints, which had already been pre-decided, is that if the study showed there was a difference between the two groups of just 5 millimeters in the office blood pressure, or in the 24-hour blood pressure monitor of just 2 millimeters, then it was going to be a positive study. So with what had come up in Symplicity 1 and 2, it was felt that this is going to be quite easily achievable. Unfortunately, with the denervation arm and the sham arm, there was an impressive change from baseline, 14 millimeters in the denervation arm and 11 in the sham arm. But when you compared the two, there was no significant difference between the two. Similarly, as far as the 24-hour blood pressure monitor goes, though there was impressive fall in blood pressures in both arms, when you compare the two, there was no difference. So it could not even reach a significant value of 2 millimeters, which had been pre-decided. So why is the data from Symplicity 3 so different from 1 and 2, and why does it make us rethink the entire procedure? Well, this is the first sham study which has been done, which is the standard of care for any device. It's felt that the first 2 studies probably had a Hawthorne effect. That is, people who had the procedure, they felt they were under scrutiny, they would be more compliant with the medications, whereas the people who were in the control arm were not probably taking the medications, and it was not really the adherence was not, or compliance was not really followed up. Well, we have a 6-month follow-up. Can we hope that as these people are drawn out every 6 months till 5 years, may it improve? Yes, it possibly could. How about figuring out whether these renal nerves are really denervated? That involves a lot of study, including checking for the noradrenaline spillover and checking the renal blood flow, and all the people in the trial were certainly not subjected to this. How about which patients should be picked up for this procedure? Certainly not mild hypertensives. It is resistant and refractory hypertension. So these are people who are having uncontrolled blood pressure despite being on 3 medications, of which 1 should be a diuretic. And it says that we definitely need to further research into this procedure. Is this the end of the road for this? I think there is some light at the end of the tunnel. Besides the hypertension, the different studies have shown that there is an improvement in LVH and improved diastolic dysfunction, which may or may not be related to the blood pressure improvement. These people have often different problems with the sympathetic system, and they improve as far as their glucose metabolism goes and insulin sensitivity, so good for diabetics. People who have got obstructive sleep apnea have also been shown to improve after the procedure as far as the apnea hypopnea index goes. There's an improvement in arrhythmias. For instance, people who underwent pulmonary vein isolation, they had a reduction in AF recurrences. People who had AF, they had a reduction in the ventricular response. Also improvement in anxiety and depression and PCOS. I mean, we can go on and on, but I think I'll end here and probably lead on to a discussion about what you think is the status of this procedure.